So it came out at various times when we were discussing the disease products, the disease and the use of different products, that one of the problems we had in comparing the products was the different toxicity scores that used to go on. I thought we had a really great last session. I know it wasn't everybody's cup of tea, but I loved hearing that session and loved hearing the people that were engaged in putting it together, talking about how they came up with what is now in the consensus guidelines for these. And of course, we've now got the tools in place to be able to think that prospectively now we'll be able to have a more standardized approach. You are a little critical that we've seen a lot of the things collapse into grade 2 toxicities, and we'll come back and talk about that in a moment. What I also really liked in that session was the really practical guidelines from people who are really experienced at dealing with these things, telling you what they do and how much it's clear that that has been a moving process as we've gone. It's not that so long ago that we didn't think we should intervene because we thought we would interfere with the expansion of the CARs and their efficacy. So what's your sense?
I don't think we've seen all the data yet.
Yeah, sure.
On this area, right? And I think it's going to be more contentious after ASH potentially, from some data I've seen already. But I think what we've seen is there's been an evolution of therapy. If you remember Jim Korkendorfer, when he did the original trials with what became iwCAR-T, they didn't intervene at all. For severe neurotoxicity or severe CRS, they very rarely gave anything, right? And people, they all essentially recovered. So I think we've moved clearly to a different level where we're intervening early. I've heard many people are now intervening on grade 1 CRS if it's persistent for more than 3 days, and people are intervening. We never would do that in the past. We would intervene originally just to keep people out of the ICU, and even in the peds, that was not even the case, right? It was like, I think in the original Tisagen Laclusil trials, it was if you're on your third pressor, then maybe you would intervene. So we've clearly moved, and even within the clinical trials, we've moved from later to earlier. And so I think
that's a really interesting point, because of course it came up that a lot of people from industry and Steve Schuster are saying that we could just look at the intervention and that will tell us how we can compare the products. But I was picking up from the audience that just about, and you said it yourself, 8 attendings in Penn might do something slightly different. So there are differences in opinion as to whether and I think Rebecca Gardner was the one who said we prophylax the treatment rather than react to. So it is very much a moving field, and it does make it difficult to know, again, looking at TOSI use. And I think you also commented, of course, that you're looking at the grading with the use of the intervention no longer also kind of matches up. Yeah. So how do you think about when and how we intervene?
Yeah, so I think looking backwards and trying to compare outcomes across different trials with different grading scales, we're trying to do that, but it's fraught with error. And I think you mentioned Rebecca Gardner presenting her data today, using the same product longitudinally over time with a different intervention strategy for CRS, and the incidences and severity of toxicity changed within the same group of patients, the same product, just based on how you're managing toxicity. So it's really a big challenge. So I think the development of a consensus grading scales for both neuro and CRS toxicity, everyone in the field, at least on the clinical side, taking care of these patients and reporting data, felt a tremendous need to do that. I think no grading scale will be perfect. But what I think the goal of the grading scales is to try to really identify key clinical criteria without making it too complicated to potentially be used as a scale going forward in future clinical trials, and as a way to interpret what's happening at your own center with commercial products as you use different products and gain familiarity with how they may behave differently.
Sure. Yeah, my problem with our current grading, again, I like it, but we're now only kind of reporting the grade 3-4 as being serious, right? And in fact, many patients with grade 2 are quite serious. And if you look at the real-world experience with iwCAR-T, 32% of patients ended up in the ICU, but only 7% technically had grade 3 or greater toxicity. So now we're using.
David, even that's difficult because different centers have different views on when, some people reserve ITU, clearly reserve ITU for the patients that need it. And of course, you've got a facility where you've got everything prepared to do
absolutely,
that. Other people
true,
move a CAR T-cell patient to ICU at the first sniff, don't they?
No, they do. And I think, but that's why, how do you compare them accurately between products if everyone's doing a different way of management? So what I was hoping was that the grading scale could be used as a way of actually kind of normalizing toxicity across the products. And it doesn't really seem to easily be able to do, because when you look in like oxycaptogene, I mean, there was only a 7% grade 3 or greater CRS, but 50% of people ended up getting TOSI. So as you said, everybody's reacting differently. We're giving interventions earlier. The REMS programs are actually different. They don't prescribe the same thing. Even if you're actually trying to follow the product label, people do different things. And our center, we wrote our own kind of policy and just said, well, we're just going to use that because we can't figure out the nuances. And in the middle of the night, if they call you and you're supposed to try to figure out which product did they get and which REMS program are you intervening with, it gets kind of crazy. And I think that's why I think the FDA should mandate a uniform REMS program. It's never probably going to happen, but there should be like a uniform REMS program. Once you have training on how to deal with CRS, that should be good enough, and we should then be able to learn from the other products and come up with a consensus.
So there, I think you can probably see that we could spend the rest of the evening talking about the excitement that we got out of today, and there's lots more we could talk about, but here we are. That's the end of day 1 from iwCAR-T. We look forward to another exciting day tomorrow, and thank you very much for joining us.